Let's now take a deep dive into one of the alternate payment models, the bundled payment model. Because many models focus only on isolated procedures, in the bundled payment model, we lump all the services that are related to a treatment and condition. And we will see through a case study, after I briefly demonstrate how this works with two sample examples, how a model like this has shown clear evidence of improvement in access and outcomes, even in resource constrained situations. Okay, so how are they getting paid in a bundled payment model as opposed to a fee for service model where they keep getting paid for doing stuff? So what happens in this model, is that providers are paid a lump sum. All services related to a treatment or a condition or a procedure over a defined duration or a defined period of time that is agreed upon between the provider, the hospital, and the recipient, the patient. And this lump sum is based on an estimate of what might be the expected costs of treatment. Clearly, the provider is incentivized to control care expenses of patients so that they do not exceed the budgeted amounts, and the duration of time makes sure that there are no untoward incidents in terms of readmissions or other complications. So here you have a model that tends to control costs and also provide better outcomes. Let's try and look at this with a practical example. What I show you here is the joint replacement bundle. So in this case, there's an episode trigger. There is an admission. The joint replacement surgery costs are estimated. And then the bundle includes a 90-day post-discharge. The episode starts with an anchor, the hospitalization as the anchor, where the patient undergoes the joint surgery replacement. The patient is then provided physician services, skilled nursing facilities, and probably some level of inpatient rehabilitation facility, long-term care if required, and physical therapy on a daycare basis. The patient is then monitored at home for a period of 90 days to ensure that there are no readmissions, and if there are, then they are part of the overall cost, which includes this entire bundle. And at the end of those 90 days, from the hospitalization, the bundle ends, the episode ends. So this way, you're not being paid, the provider is not being paid for individual events or episodes, which is what the fee for service mandates. Let's look at another example, the pregnancy bundle. So the episode triggers with checkups and prenatal visits. There is education through the process of pregnancy. The patient is admitted in the hospital for admission and childbirth and is provided 6 weeks of postpartum care and psychosocial support, at which point the episode ends. So as you can see, the skilled nursing facilities, inpatient rehabilitation, long-term care, physical therapy, psychosocial support, all of these are included as part of this bundle. And because all of these are included over a duration of time and the provider is paid a specific amount, there is incentive for the provider to control costs so that they make better margins on the overall cost that they have agreed with the patient. And also for the patient, there is a higher chance that the hospital is doing the right thing and not just motivated to do more. And let me demonstrate this with the help of how this model was applied in pregnant women in sub-Saharan Africa. This is called the Mom Care case study. Now, we know that the health outcomes remain poor for pregnant women in sub-Saharan Africa. This, despite much of the poor outcomes, are actually easily preventable. The government intervened. There was significant provision for increased care budgets for this particular situation, but it did not improve outcomes or quality metrics. Farm Access, a foundation that addresses healthcare gaps in Africa, attempted this bundled pay model, which we just described, for pregnancy that included the entire spectrum, as we described, from antenatal care to delivery to postnatal evaluation and immunizations. This particular study covered over 29,000 mothers in Kenya, mostly from Nairobi and rural areas surrounding Nairobi. These 29,000 studies or 29,000 mothers also included up to 10% of very high risk pregnancies. So close to 3,000 of them were very, very high risk pregnancies. Just the application of this particular bundled pay model demonstrated significant impact, and the results were absolutely astounding. Let's look at the results and the impact from an accessibility and affordability standpoint. The following observations were in evidence. So when these 29,000 mothers were given access to this pregnancy care using this bundle, mothers were empowered through increased awareness about delivery signs, perinatal danger signs, breastfeeding, and follow-up for appointments. The providers were forced to look at early risk stratification and thereby improving care for high-risk mothers. The results, quantitative, both clinical and economic, were astonishing. One, there was a 16% increase in adherence to antenatal care visits for all mothers. And for those mothers that were high risk, the study found a 25% increase in compliance and adherence to prenatal and antenatal care visits. There was a 15% increase in antenatal care visits that included a full set of hemoglobin, syphilis, HIV, blood glucose, urine, and tuberculosis tests. Not only all of this, there was almost a 17% increase in completed pregnancy journeys. And this was associated with an almost 40% decrease in journey costs for women who deliver through cesarean section. This is quite astonishing. I feel like bowing down and saluting these women folk who participated in this study. Asante Sana Mama. They gave themselves and their unborn babies better odds in a resource-constrained situation. If poorly resourced areas like sub-Saharan Africa, where women folk face challenges that we cannot even imagine, and can lead the way and demonstrate these results using a simple alternative payment model, we have no reason or excuse not to investigate and invest more in similar alternate payment models around the world.